I spend this much time programming hearing aids possibly because I'm really bad at programming hearing aids. Hey guys, welcome back to the DrCliffAuD vlog, and today I want to explain to you exactly why I take so long to program a pair of hearing aids at a patient's initial hearing aid fitting. But before I do me a huge favor, click the like button, really helps out the channel, and if you are not yet subscribed to the channel with notifications turned on, go ahead and do that as well. It is greatly appreciated. So a couple of vlogs ago, I think vlog 253, I was explaining why I take so long during initial hearing aid consultation to make sure that I'm able to properly test somebody, properly get a good case history, and make a solid recommendation on their treatment, and make sure that they understand why I'm making that recommendation. And so that initial consultation takes 2 hours for me to complete. Now, that has kind of posed questions inside of my audiology community of, well, how long does it really take you to program a set of hearing aids once you know the right hearing aids for the patient? And when I say that it takes me 75 minutes to do an initial hearing aid programming, a lot of people are like, why the heck does it take so long? I can fit a pair of hearing aids in 20 minutes. And I'm just like, I have no idea how anyone gets through a good, solid hearing aid programming in 20 minutes. So I'm going to kind of walk you a little bit through what my approach is when it comes to programming a new set of hearing aids for a patient. So first and foremost, the most important thing I need to make a patient understand in the initial hearing aid fitting is that I want to make sure that they understand everything I'm doing and why. So I basically take time to explain every step that I'm doing and why I'm doing it. So by the time that they leave, they're like, okay, I have a really good understanding of what he's trying to do from a hearing treatment perspective with me. Now, the first step after that is to make sure that we get a good, solid hearing aid physical fit. Now, about 80% of my patients have a custom ear tip that goes inside of their ear if they're not wearing a full-on custom hearing aid, which means that I have to make sure that the digital scans that I did and the ear molds that I had fabricated for them actually fit comfortably inside of their ears. And once I confirm that they're fitting comfortably inside of the ears, I can move on to the next step. But I also have to do the exact same thing with rubber domes. You have a variety of different rubber dome styles that you would have to select based on an individual's ear canal size and shape and the configuration of their hearing loss. And then in some cases, you even have to use a retention filament to keep that dome up and inside of their ear canal. But once I identify, okay, this is a good, comfortable physical fit, then I have to move into the quality of the acoustic fit, which means I have to run a feedback manager. Now, I know that some audiologists don't run feedback managers, but I like to run a feedback manager because it tells me where leakage of sound is happening out of their ear canals. It can tell me if a vent is too small or a vent is too big. It can tell me if the vented domes are allowing too much passage of sound, if an open dome is completely inappropriate, and then if a closed dome is too occluding. So when I run this measure, it will show me where the leakage is, and if I'm like, you know what, that actually doesn't look very good, I don't think I'm going to be able to hit your prescriptive targets if we leak that much sound out of your ears, then I have to switch it into a different dome or make sure I request a different custom ear mold. Now, requesting different custom ear molds doesn't happen very often. In most cases, when I'm sending off a 3D scan to a manufacturer, I'm also giving them their audiologic information, which means that they're calculating the appropriate diameter, size, and shape, and all of that of the actual vent itself to make sure that it is acoustically appropriate for a patient's hearing loss and their ear canals. That being said, once we confirm that the ear mold or the dome is appropriate, then we can switch into real ear verification. Now, some hearing care professionals will not do real ear verification, otherwise known as real ear measurement, during their initial hearing aid fitting. The reason why I do it at the initial hearing aid fitting rather than just going with the first fit settings when you enter in an audiogram and hit auto program is that it never tells me, if I don't do it, I have no idea if the way that I'm physically setting the patient up with these hearing aids is going to be able to allow me to hit their prescriptive targets, primarily in the high frequencies, okay? So what could happen is that if I did not do verification and then I fit them with the hearing aids, I send them home, they come back. If they have a complaint about the hearing aids, then I have no idea if it's because we're over-amplifying, under-amplifying, if we're even coming close to a prescriptive target or anything like that. And then I would have to go right back to the drawing board to square one to do the physical fit again and do the programming after we do a feedback manager test, right? So I just don't like wasting time. I mean, I take a lot of time, but when you commit time up front, it prevents you from having to spend even more time on the back end. So that's why I'm willing to take a full 75 minutes for something that takes a lot of places 30 minutes or less to complete. Now, once I precisely match an individual's prescriptive targets, I explain to them what they're looking at on the screen. So basically, the patient is grading me and how good I'm doing. And I'm helping them understand the process of all of this along the way. If they can read their own prescriptive match, then it helps them know when they go home that, like, okay, these hearing aids I know are objectively programmed the right way. After I do it for average level speech, I also adjust compression settings, which means that I give different amounts of amplification to loud level and soft level speech. I run a maximum power output curve. I even play some calibrated English speech at a very soft level so they can tell me what they're saying and how clear and understandable it is, even though it's at a softer level. So I'm doing a lot of different verification measures inside of their ears. And again, educating them along the way of why this stuff is important, because the better understanding a patient has when I'm doing the fitting, the better they are at coming back at their follow-up visits and reporting to me what's going on. And then if I have to go in and make a change, they already have some foundational understanding of what my initial settings were that I have to switch off of based on what their feedback was to me. Once I get a really good prescriptive match, sometimes I have to reduce the amount of amplification because a new patient with new hearing aids is typically not going to be able to tolerate their full levels of amplification because their brain is not primed for it yet. It usually takes anywhere between, 20 and 30 days before someone gets fully comfortable with the amount of amplification. So we start them off a little bit lower and then we baby step them up into as close to their full prescription as we can possibly get them. Now, once they have that understanding, we move on to all the other digital features inside of the hearing aid. Now, most of the features I will leave on their default level settings, meaning that they all come with some level of like noise reduction, speech focus, directional microphone, stuff like that. But I want to leave all of those on their starting levels. So I know if someone's coming back with reported difficulty, I can go into them and adjust them either stronger or weaker depending on what their reporting is. Now, the other thing is that I might be activating some other relatively inconsequential features like a tap control or something like that and having them train on how to do it so they can, double tap their ear to answer phone calls, double tap to hang up, double tap to pause and resume streaming from their phones, things like that. The other thing that I'll do is I'll play different sounds like the low battery signal, the connection signal, the program adjusting signal, like all of these different signals that they might be getting randomly from what they think is randomly from their hearing aids, but they actually have meaning. So I try to play them initially. Ultimately, a lot of patients will come back saying, hey, I heard this other sound. I don't even know what that sound was. And we have to go in and figure out what those sounds are. And I can play some of them again to them and they can tell me, oh yeah, that was the sound that I heard. What is that actually? And it's like, oh, well, that's your low battery signal. So there's a lot of educating that goes into the initial hearing aid fitting. Now, I could just go and do all this stuff under the radar, meaning I could probably do all the things and not explain anything to a patient and cut an additional 15 to 30 minutes off of an appointment time. But I do truly think it's important that everyone that I fit with hearing aids has at least a foundational understanding of what I'm trying to accomplish. And if they can't remember the stuff that I'm doing, I can review it with them at a future appointment just to kind of refresh their memory. But I think it's very important that right out of the gate, when you're getting thrown into something that's totally new, like a new set of hearing aids, the more you can possibly understand, the better. Now, once I get all the initial settings done and I activate data logging, which now it requires that I get their permission because of the FDA for me to track data inside the hearing aids, like different acoustic environments, what they're doing, volume control, so on and so forth, so I can read that at future appointments. Now, once I'm done with that, I disconnect them from the hearing aid software. And then we go into the pairing process of the hearing aids with their smartphone, because most people want to be able to stream phone calls, stream music, stream other audiobooks, things like that. So I want to make sure we get the hearing aids set up to do all that streaming and then actually run through a demo. So instead of me being like, okay, give that a shot when you're at home, let me know how it works, I actually do it with them in the office. I'm like, okay, I'm going to give you a call. What's your phone number? Give them a ring. They double tap their ear or answer it on their phone, and I make sure that the sound coming from me to them is of good quality. If it's a little bit on the lower side, I educate them to show them how to turn up the volume. If it's too high, I teach them how to turn down the volume, so on and so forth. But I always want to make sure that I'm confirming that everything I'm setting them up with actually works, because sometimes it doesn't work and I have to go in and do a workaround for a patient in that particular instance. But if anything can make someone confused in the first week, is that if you activate all these different features and Bluetooth and all of that, but you don't explain how any of them work, you're basically setting someone up for lack of success in their initial week of treatment. Now, once I get done with that, I make sure that I teach them how to put the hearing aids in the charger, take them out of the charger, change batteries if they use disposable battery hearing aids, so on and so forth, so they know how to actually power up their hearing aids. And then I teach them how to put them in their ears and take them out of their ears, because if you can't do that, then you're pretty well screwed. So making sure that we have enough time for every type of patient, whether they're good with their finger dexterity or whether they're bad with their finger dexterity, to be able to actually physically get the hearing aids in and out of their ears is arguably the most important thing that we do at an initial hearing aid fitting. After that, it's my job to give them realistic expectations with those particular hearing aids, meaning here's the types of things that you need to be aware of. Don't let your dog eat the hearing aids. Don't you eat the hearing aids. Don't swallow hearing aid batteries. It takes at least 30 days for your brain to fully acclimate to hearing treatment. Some sounds will be annoying. Make sure that you note what they are and bring them back to me. My ability to be good at what I do depends on how much feedback I can pull out of you at your follow-up visits, so make sure that you keep a journal. I also need to make sure that we identify certain things that they can use as a gauge for how much improvement they're having with their hearing treatment. I like to use the COSI, which is the Client-Oriented Scale of Improvement. This is a subjective outcome measure that's been validated to where we actually, before they go out with the hearing aids into the real world, instead of just asking them, well, how did that sound? We have to identify very specific things that they can use to do a pre and post comparison with the hearing treatment. That is the only way we can know for sure that they're getting subjective benefit based on the objective data that we have used to set up their hearing aids appropriately. Once we get all of that stuff done, which I'm telling you takes a good 60 to 70 minutes to do if you're going to do it at a really high level and explain a lot of these concepts in a way that is easy enough for somebody to understand, then we move on to reviewing the purchase agreement. It's very important. In fact, it's usually required by states that you review the purchase agreement so they understand the warranty dates, the loss and damage coverage, whether or not their hearing aids have a telecoil, if they qualify for a free caption telephone, all of these different things. It should also indicate what your return window is. So if you're not having success with your hearing aids, we need to know by this particular date so you can return the hearing aids for a refund. And if you keep them beyond that date, we can't return them. So making sure that they have a detailed understanding of that, and ultimately here's how much it's going to cost, how much you still owe rather, up at the front desk, and then ultimately signing the purchase agreement so we can scan it into our system but send our patients home with the original document. Like I said, it takes every bit of 75 minutes to do a really high-level hearing aid fitting. Could you get away with doing less amount of time on a hearing aid fitting? Absolutely. People do it all the time. If you go get hearing aids from an ENT clinic, they might have a 10-minute hearing aid fitting with you and basically send you home with a user manual to try to figure out your own hearing aids. But in my clinic, with the amount of money that we typically charge people for their best practice fitting sequence, we want to make sure that they get what they pay for when they come into my clinic. And some people are like, Cliff, my other provider was able to fit me for free. I'm like, good luck, go back to your other provider. In this clinic, we do things at a really high level to make sure that you're going to hear your absolute best. But let me know what you guys think. Do you think that 75 minutes for a hearing aid fitting is way too long? Do you think it's just right? Do you think it's too short? I would like to know your opinion down in the comment section.